Muruganathan, physician from Tirupur, past president of the Association of Physicians of India. My topic today is the BP target of 120/80, rationality of BP of 120/80 in the management of hypertension. Whenever somebody comes, when you ask what is the normal blood pressure, even from our student days, we used to say 120 systolic and 80 diastolic, 120/80. That is what is the rationality of this target and what is the reality in the real world? You know, hypertension is the major cause of premature death worldwide. It accounts for more than 140,000 million disease-adjusted life years, DALYs, attributed to systolic blood pressure alone. The high systolic blood pressure causes 50% of deaths due to stroke, ischemic heart disease, and chronic kidney disease in India. 1 in 3 adults in India suffer from hypertension. A tighter target of blood pressure control of less than 120/80 or 130/80 is often desired in individuals, though it is not practically seen here. In 2002, Lewington has said, by analyzing 61 prospective meta-analysis observational studies and 1 million adults, said the risk of cardiovascular mortality doubles with each increase of 20 systolic and 10 diastolic. So he said from 115 to 115 systolic and 75 diastolic, each 20 millimeters of increase in systolic and 10 millimeters of diastolic increase the risk by double fold. So when 135/85, you get twofold increase in cardiovascular problems. So basically, his idea was, to keep the blood pressure well below 120/80. And he also said each 2 millimeter decrease in systolic blood pressure reduces 7% of ischemic heart disease and 10% of the stroke mortality. So that is the importance of reduction of even 2 millimeters. And there were so many guidelines confusing. Now, the target and the definition of hypertension is a moving goalpost. In JNC 7, they said 120/80, and JNC 8 said 140/90. Then American ACC guidelines says 130/80, or the definition is, before 130/80 is hypertension. In the ISH guidelines, in the recent one, they say 130/85. Indian guidelines says 140/90. And recent WHO guidelines in 2020-21, 140/90. So all the guidelines give different pictures and definition. But the target, if you can achieve 120/80, it is very, very welcomable, very, very, very good and beneficial. But, is it possible? The intervention trials that defines target BP in concordance with the evidence from studies between 1997 to 2003, the National Heart, Lung and Blood Institute expert panel of 2007 and 7 Joint National Commission recommends a lower systolic blood pressure goal of less than 120 in the prevention of hypertension-related complications in patients without diabetes. Several meta-analyses do not provide a strong evidence for one size fits all in BP target. A CORD trial, a RIN2 trial, AASKD trial, all fail to show the benefits of intensive BP control, whereas SPRINT trial elucidating the benefit of a tighter BP control. In the UKPDS, they said every 10 millimeter decrease in mean systolic blood pressure reduces 21% of the myocardial infarction, 44% reduction in stroke, and 56% reduction in the heart failure. Same way, the heart trial says if you reduce the diastolic pressure from 90 to 80, there are a lot of major cardiac events can be reduced. And lots of meta-analysis that favors cardiovascular events, optimal blood pressure less than 120, minimizing the risk factor, like, Hung et al., Gio et al., Bundy et al., Shen et al., Bangalore et al., all of them, by studying in various prospective studies, said lesser the target, more benefits. And then what are the challenges in defining BP targets? The definition of target BP itself is a moving goalpost that transits with the guidelines based on contemporary evidence, target population, maybe adult versus elderly, even elderly, fit elderly, frail elderly, difference in, those situations also, the BP target varies. The mode of BP measurement, whether it is home BP monitor, it is office BP monitor or ambulatory BP monitor. Existence of other comorbid conditions like diabetes, CKD. and also called J-curve phenomena in the diastolic BP control. One should make every effort to minimize adverse events, even if it means that target BP is not below the current recommended levels. If you see the different BP measurements, for BP, the normal we say 135, less than 135, and diastolic 85. Office BP is corresponding to home BP is 140/90. Ambulatory measured during the day is 135/85. Measured during the night 120/70. And 24 hours period of ambulatory is 130/80. So, ladies and gentlemen, depending on the instrument, depending on the time, and depending on the age, and depending on the comorbid conditions, the target and the definition changes. And also, when you compare the office targets in major different guidelines, when there is comorbidity, for example, ACCA guidelines says diabetic mellitus 130/80. Japanese guidelines says 130/80. When you have proteinuria, 130/80. When you have cardiovascular risk, then 130/80. So, depending on the comorbidity conditions like stroke or proteinuria or diabetes or kidney disease, the target is varies. The intensive BP control trial by the SPRINT trial proved reduced risk of myocardial infarction, stroke, acute coronary syndrome, heart failure, and death from CV causes. And also says result in lower rates of developing LVH in those without LVH and higher rates of regression of LVH in those with existing LVH. There is a post hoc analysis that survival benefits of intensive BP control, especially among middle-aged adults at risk. So intensive BP control benefits, cardiovascular benefits, better quality of life, but risks are there in the intensive control systolic SPRINT trial. Hypotension, syncope, acute kidney injury, injuries and falls, poor adherence and discontinuation. In ACCORD trial, significant benefit was not seen, was seen with secondary endpoint like stroke reduction, but no difference was seen in the primary endpoint like myocardial infarction, non-fatal stroke or CVD death. Serious adverse events were significantly higher in the intensive group. No changes were seen with regard to renal function or other microvascular complications. So there is a discrepancy and controversies between the tighter control of SPRINT and ACCORD. SPRINT with enrolled people without diabetes found a benefit with intensive systolic blood pressure control, but ACCORD with enrolled people with diabetes did not. Too much of tighter control could be detrimental in certain population. Benefits must be carefully weighed against the harms. Effects should be made in a way that to minimize adverse event, even if target BP does not meet the currently recommended levels. The J-curve phenomena, in simpler terms, when elevated blood pressure is lowered, the risk of CV event decreases, but lowering BP below a critical nadir is no longer beneficial and possibly deleterious, thus shaping a J-curve. A J-curve phenomena is unlikely to occur until lower values are reached, except perhaps in patients with advanced CAD. And the TNT analysis says fourfold increase of CAD when the BP is lower in a diastolic less than 60. Lowest point is 112/72. It's preferable not to lower diastolic blood pressure below 70. So caution lowering systolic blood pressure below 120, below 110 to 120, especially if the CHD is present. Caution lowering the diastolic below 60 to 70, especially if CHD present, because the diastolic time only the coronary perfusion happens. Focus on identification of selected patients may be more likely to benefit from more intensive blood groups of gold in a long life expectancy, chronic kidney disease, and albuminuria, as well as those at high risk of stroke. Young may be less susceptible to adverse effects associated with more intensive therapy and may benefit from tight pressure control. So individualizing blood pressure goals is very important, because definition of defining a BP target for all possible clinical scenarios is not possible. So an individualized approach is required to set the BP target, because most of the hypertension guidelines set the BP target based on coexisting conditions and age. So one size fits all, independent of age, comorbidities, is not evident, and several meta-analyses do not provide a strong evidence for a single BP target in all population. Blood pressure goal depends on a valid clinical judgment after careful evaluation of the possible risk versus benefits that defines an achievable target. So age and comorbidities and frail individuals should be considered before implementing. And when you prescribe an antihypertensive drug, that should have a longer 24 hours control with high trough peak ratio, with which is not hindering the BP variability, which affects the BP variability, and also an ideal drug with which also the time in target is also covered. So when you do all that, a tighter target BP control of 120/80 or 130/80 is often aspired in individuals who are not currently meeting the target. Definition of target BP itself is a moving goalpost that transits with guidelines based on contemporary evidence like target population, existence of comorbidities. Recommendation of intensive BP control seems optimistic. Too much of tighter control could result in acute kidney injury, increased occurrence of hypotension, increased incidence of syncope and injuries falls. A target BP must cater to the requirement of individual patient. A target BP can be the lowest of the recommended optimal BP that can be tolerated by the patient, taking into consideration benefits harm ratio without compromising on their quality of life. So ladies and gentlemen, kindly promote the concept of hypertension clinic and hypertensionologists to achieve the target, to create an awareness and to control the hypertension, to reduce the economic and health burden of the country and the globe. Thank you very much for your patience.